Borderline resectable pancreatic cancer, BRPC. Definition: borderline resectable pancreatic cancer, BRPC, is a stage of pancreatic cancer where the tumor is in close proximity to vital blood vessels, making surgical removal, resection challenging but not impossible. The tumor's relationship to these blood vessels is the key factor in its classification, as it impacts the likelihood of achieving a complete R0 resection without residual tumor cells. BRPC is an intermediary category between resectable and unresectable pancreatic cancer. While resectable tumors can be surgically removed with minimal risk of leaving cancer behind, BRPC poses a higher risk of incomplete resection or complications during surgery. Anatomical criteria. BRPC is defined based on the tumor's involvement with the following major blood vessels. 1. Celiac axis, CA. 2. Superior mesenteric artery. 3. Superior mesenteric vein, SMV. 4. Portal vein, PV. Guidelines such as those from the National Comprehensive Cancer Network, NCCN, outline the specific criteria. Arterial involvement, tumor abutment, 180 degrees of the SMA or CA. Venous involvement, tumor encasement or narrowing of the SMV or PV that may still allow for reconstruction. Biological and clinical factors. BRPC may be associated with borderline or questionable operability due to factors like suspicious lymph node involvement, elevated tumor markers, e.g. CA19-9, patient's overall performance status, or comorbidities. Management of BRPC. The management of BRPC requires a multidisciplinary approach involving surgeons, oncologists, radiologists, and other specialists. 1. Neoadjuvant therapy. Goal: to shrink the tumor, improve the chances of complete resection, and address microscopic systemic disease. Types of neoadjuvant therapy. Chemotherapy. Regimens like FOLFIRINOX, 5-FU, leucovorin, irinotecan, oxaliplatin, or gemcitabine, nab-paclitaxel. Chemoradiotherapy. Combines chemotherapy with targeted radiation to shrink the tumor and manage vascular involvement. Advantages. Improves the likelihood of R0 resection. Allows for early treatment of micrometastases. Identifies patients who may not benefit from surgery due to disease progression during therapy. Number 2. Surgical resection. Performed only in cases where the tumor responds to neoadjuvant therapy and resection is deemed feasible. Common surgeries include pancreaticoduodenectomy, Whipple procedure for tumors in the pancreatic head. Distal pancreatectomy for tumors in the body or tail of the pancreas. Vascular reconstruction may be necessary if the tumor involves veins like the SMV or PV. 3. Postoperative adjuvant therapy. Chemotherapy is often continued post-surgery to reduce the risk of recurrence. Radiation therapy may be considered based on the tumor margins and lymph node involvement. 4. Surveillance and follow-up. Regular monitoring with imaging, CT MRI, and tumor markers, CA19-9. Follow-up aims to detect recurrence early and manage complications. Challenges and prognosis. Challenges. Achieving R0 resection is technically complex. Risk of recurrence is high even with aggressive therapy. Limited therapeutic options for systemic disease progression. Prognosis. Median survival with BRPC is significantly better than unresectable disease but worse than resectable cases. Patients undergoing R0 resection after neoadjuvant therapy have the best outcomes, with median survival extending to 20 to 30 months. Emerging approaches. Targeted therapies, exploring molecularly targeted treatments for mutations, e.g. KRAS, BRCA. Immunotherapy, investigating immune checkpoint inhibitors. Clinical trials, developing novel neoadjuvant and systemic therapies. Effective management of BRPC requires personalized treatment strategies, emphasizing the integration of systemic therapy and advanced surgical techniques.